Welcome to the Exchange Wales podcast, a series that explores research and practice sharing, evidence and care experience to build better social care in Wales and beyond.
Welcome to the Exchange podcast. My name is Jeremy Dixon, and I'm really pleased today to welcome Dr. Robert Lomax, who is a senior lecturer at the University of West of England in Bristol. Rob, thanks very much for coming to the podcast and for talking about your new article in the British Journal of Social Work. So, full disclosure, we have met before, and we initially met when we were both working in a mental health team in Bristol. So I guess I was going to ask you to tell me a bit about your background, really. So you've come from practice and then into academia. So tell us a bit about your journey there and what made you kind of be interested in looking at the topic of mental health work.
Thanks, Jeremy. Yes, so I've been a social worker for many years and worked in practice in a variety of mental health teams, so crisis teams, certified outreach, primary care teams in different parts of the country. And then I moved to work in academia for the last 15 years or so. And what I found was when I was working in mental health teams, really, I worked with lots of different professionals, as you'll know. So psychiatrists, psychologists, occupational therapists, all kinds of different professions. And I found that experience quite interesting and found that experience quite particular. And so I think as a practitioner, you learn to navigate working with different colleagues from different backgrounds, different professions. And so I've just always been interested in multidisciplinary work. And that kind of led me down the research route to looking at that in a bit more detail.
Yeah, and I guess working in mental health teams, I worked also in a lot of mental health teams over many years, and multidisciplinary tensions were always quite stark, aren't they? I mean, I suppose what would be the typical makeup of a multidisciplinary team in a mental health setting?
Yeah, so there's usually a variety of roles. Some of those will be professional roles, so people who've studied for a particular qualification, so psychiatry, psychology, occupational therapists, social workers, nursing, that's mental health nurses. So they're probably the majority players in terms of the makeup of the team. And there might be some smaller professions, occupations represented, so maybe art therapy or music therapy, or other kind of counselling type roles. And then sometimes I think there's also sort of unqualified roles, which sounds harsh, but what I mean by that is people who've experience in working in mental health care, experience in trying to support people who are having mental health challenges but haven't necessarily studied for a particular qualification to do that role at that point in their working life. So it's quite a mix of people. I think it varies greatly between areas of the country, different nations within, different developed nations within the UK. So right down from the kind of national level to a kind of local, regional level, it will vary. But it's essentially different professions working in one team trying to support people who are having mental health challenges at that time.
Yeah. And I think social workers can vary, can't they, in how comfortable they feel themselves to be in those kind of teams. So, would social workers be equal in terms of numbers to other professions usually, or would it be different to that?
I think typically the most numerous profession in the multidisciplinary team is probably going to be from a nursing background, and social workers are going to usually be a smaller number. So certainly my experience and experience of people I've known and worked with is that as a social worker, it might be 2, 3, 4 of you, but it's more likely to be, a dozen plus of nursing colleagues or something like that. So you always had that feeling of being numerically a smaller group, but then also perhaps more significantly or interestingly, also a minority perhaps in how you view the phenomena of mental health and how you might want to go about supporting people. So it's not just about kind of the makeup of the team in terms of numbers, but really about essential ideas and philosophy and understanding about what mental health is, what poor mental health is, what causes it, and what you might want to do to try and to help people.
Yeah. And you do cover some of those things in your findings. So I think we'll probably come on to that in more detail later on. I think before we get to that, it'd be useful just to think about policy, which can sound a bit dry, but in some ways it's kind of necessary to understand that. So I guess when I started working in mental health teams, which was a long time ago when I was a student, late 90s, social workers were separate from other health professionals. So, we were all kind of based in a hospital when I was a social work student, and nurses were in a completely different team. And then I think somewhere towards the late 90s, early 2000s, there was this kind of drive to integrate health and social services. So, how did that come about, and what was the thinking behind that?
If you sort of take 1990 as just a point of reference and the introduction of the Community Care Act, which in itself was not out of the blue in terms of its aims, which were to promote community care, reduce reliance on institutions in all sorts of areas of health and social care. So there'd been a move to kind of deinstitutionalization, the closure of the large old asylum hospitals. Through the 60s, 70s, the 80s, the Community Care Act continued that trend and really started to promote the idea of health and social care working much more closely together. An aspiration was that the majority of resources would be around community services rather than hospital services. And so it's within that, the idea of multidisciplinary working developed a little bit more. So there's kind of at a more macro level, there are kind of processes trying to get local authorities and the NHS to pool budgets, to share processes. And then part of that became about co-locating. And one critique of the kind of community care movement at that time was it was about closing large hospitals, and there was insufficient resources to support people who were then living in the community. And that's a valid critique. But also within that, you can make the argument actually philosophically, the move to integration, the move to different professionals working together, health and social care working together more closely, was actually very sound and very positive and was full of potential.
Yeah.
So, there's definitely some hope and optimism in multidisciplinary working, that if you get people with varied skills and knowledge essentially in a room at the same time, perhaps they're going to have better conversations, perhaps the barriers to working together will be less, and therefore at the end point, people who are using those services might get a better service, might get better quickly, to put it bluntly. So there's a lot of positive ideas about multidisciplinary working. But within that, there's also a further debate about the idea of the profession itself. Is it necessary to be trained and qualified in one particular profession to be able to help people, essentially? Is it necessary to have the medical knowledge of a psychiatrist? Is it necessary to have the perspectives of nursing colleagues? Is it necessary for a social work knowledge base to be in that team? Or actually, is there kind of common knowledge? Is there shared knowledge? So you also see in the literature and in working practices this idea of perhaps some posts within multidisciplinary teams could be occupied by people from different professions, and maybe that's okay. So there's not like an ideal mix. You don't necessarily need 2 psychologists, 5 nurses, and 1 social worker to make a multidisciplinary team. There's a lot of fluidity within that, and debate about the skill mix and the knowledge mix. So many people would have been a care coordinator within multidisciplinary teams. So this is a role where you are essentially the named person who is looking after a number of cases and making sure that things are being done as they should be. And that was a role that could be occupied by lots of different professions. So there was new ways of working, promoted roles which kind of broadened across professional groups. And there's the 5-year forward view and the NHS long-term plan 2019 all kind of still promote this idea of more generic practitioners delivering a range of interventions. Yeah, I think multidisciplinary work is a constant theme. I think professions trying to claim their ground, to say this is us and this is what we do, is a theme as well. But within that is a policy debate about, well, maybe also some of those professions can do multiple tasks. And so I think there's a debate and a back and forth between government and policy, and who's influencing government policy, and then professions themselves saying, no, we're nurses, this is what we do. We're social workers, this is what we do. And the need to define your territory as a profession, to have a distinct identity.
Yeah. Okay. And in your British Journal of Social Work paper, you draw on the theories of Pierre Bourdieu. And it can be useful, can't it, to use social theories like this to kind of maybe unpack what's going on and to look at it in new ways. But I guess not everybody will be familiar with these ideas. So it'd be really helpful if you could explain a bit about them. So you talk about the ideas around habitus, field, and capital, which are terms which are used by Bourdieu and other academics working with him. Can you say a bit more about what those terms mean?
So yeah, the three main ideas which are used of his in my study were habitus, field, and capital. And so habitus, if you put that simply, is concerned with how people act, feel, think, and be. Okay, so it's kind of our mode of operation. It's how we go about our daily life in different spheres. It's kind of our skills, our essential disposition. So if you take that multidisciplinary example that we're talking about today, then it's how people conduct themselves in the office. It's how they get things done as part and parcel of their daily life, kind of custom and culture, really. So Habitus, and in the article I'm talking today, we're thinking about how people go about their daily lives, their mode of operation. The second idea is field, which is really it's an analogy or a scholarly device to think about, and for me as quite a visual person, to kind of imagine different individuals interacting in a particular aspect of society, a particular aspect of life. So field can be defined differently and is defined differently by different people, and it can be quite broad. So you could talk about education as a field, culture as a field, the economic sphere as a kind of field, so quite broad. And some people would argue that social work practice itself could be a field, and that the multidisciplinary working environment might be a location within the field, so sort of a subset of the field.
Right.
But it's a place where people engage in their daily actions, essentially. So you could definitely, I would feel that you could definitely say mental health care could be used or viewed as a field. Healthcare certainly could.
Yeah.
And it's whether within that you have different locations, which you then might think about and talk about the relationship between those different locations within the field.
And lastly, capital. What does that mean?
Yeah, I think capital's a really interesting idea. So most people will think about capital in an economic sense, and we use that word quite a lot, and that's in the news when we hear news items and so on. So capital being like money and property, the accumulation of capital, the accumulation of wealth. Bourdieu wrote about capital in that sense, economic capital. And so that's quite easy to grasp about how a successful person, inverted commas, might accumulate more capital. And if they have more capital, as we know, kind of wealthy people in the world tend to have quite a lot of influence because of their capital and perhaps because of other aspects of their identity. So Bourdieu extended that idea and thought about other kinds of capital. So he talked about cultural capital. So perhaps through educational qualifications that people might have. Talked about social capital, so our kind of contacts and our friendships that might give us some sort of standing or status or influence from being well connected.
We provide free, high-quality webinars, resources, and events for social care practitioners and researchers. You can find out more information and register for upcoming events on our website, exchangewales.org.
Then he also talked about symbolic capital, which is really interesting because our high level of symbolic capital depends on other people in society, in the field, kind of believing that your capital is of value. So if you take a medical perspective and the traditional dominance of psychiatry within mental health care, doctors, psychiatrists have traditionally been seen as high status individuals who've studied for years, and then their views hold sway, and everyone to a greater or lesser extent kind of agrees with that. So when you think of different actors in the field kind of operating, working, if you take somebody who has high economic capital, perhaps is paid a high wage for what they do, has high kind of cultural capital because they've studied for a long time and have gained qualifications that are kind of recognized. Social capital, perhaps they appear to be liked by people around them, well connected in the local community. If you think of traditional models of GP practice and that kind of thing, you're then having a professional who's really well connected. So I was interested to think about capital in relation to members of the multidisciplinary team, in particular, how do social workers perceive themselves It's also interesting then to think about the resilience of different professions. So the medical profession is probably involved in all of these events, tragic events that happen periodically, but it also withstands them, it appears, in the main.
Yeah.
You sort of
Yeah.
mean.
Yeah. And yeah, it'd be interesting if we had more time to think about why that is. But I want to move on to your research where you bring in these ideas. I mean, tell us what kind of research you undertook. So what did you do when you were doing this research project?
Yeah, so I undertook a study within one English NHS trust. And within that trust area, there were about 6 local authorities who work with that trust. And I interviewed 21 social workers. Some of those I met in person, like we're meeting today. Some I interviewed online. And I was interested to know about their experience of working in multidisciplinary teams. And some of those social workers would have been employed by a local authority and then working with the NHS trust in some level of partnership. They might be based in a trust building. They might have a line manager within the trust, or they might have a line manager within the local authority. Some people I interviewed were employed directly by the NHS trust as social workers. So that's a different experience again. And some were employed by the NHS trust as a generic mental health practitioner, which I found quite an interesting idea, that you train to be a particular professional. I'm going to train to be a social worker. I'm going to do that. And then I'm going to get a job where I don't use my title in my work. So I'm not employed as a social worker. I'm employed in a post that might be done by different professionals, maybe a nurse, maybe an occupational therapist. So I was really interested to know about the experience of people who are social workers by professional background, but currently work in a role where they might be described as something different.
So it's interesting to think that through, because it sounds like there's 3 different types of social worker that you're talking about. I mean, to what extent would their job descriptions have been different? I know you won't have read them all as such, but in terms of what they were expected to do, would that have been very different, do you think?
Well, I think that's like the nub of the debate about what are kind of shared skills. And there was a policy document a few years ago about shared capabilities within mental health. What would be specific to a particular profession? So if you took the example of a generic practitioner post, perhaps being undertaken by someone who's social work trained, their knowledge about medication, for example, would be very minimal. I work in a university and train social workers. We don't have a module on medication.
Yeah.
We don't teach anything about medication. Yet someone with a social work professional qualification could get a job where there might be some hint of that, vis-a-vis a nurse who would have done that training, occupies the same role. And that was something that participants sometimes talked to me about, was that they would find themselves in generic roles, being asked to do tasks for which they didn't really have the training, and also which didn't necessarily fit with their own philosophy around mental health care.
Okay. So you have a number of different findings that you present in the paper. And the first of these kind of goes back to this idea of capital. So how social workers reflected on this idea.
So they didn't talk about, I don't think anyone talked about not having much capital, but they talked about the difficulty in being heard in some teams. I mean, overall, I was actually really heartened by the experience of interviewing practitioners. I think when I went to meet lots of them, I had my own prejudices, perhaps, about what they might say and own assumptions. And actually, many of them spoke very positively about working with lots of different colleagues in different contexts. So it was quite a positive experience. But they often talked about the social work voice perhaps not being as loud as other professionals. And from an analytic point of view, to me, that is evidence of them having a limited or kind of tentative capital in being able to express their views and get their perspective across.
Yeah. So I guess there's other people who've done research into social workers, which you mentioned in your articles. I think particularly people like Lisa Morris. And I think in their articles, as you say yourself, people were talking about having kind of low capital, or feeling undervalued in mental health teams. So it sounds like maybe that's improved, at least in the experience of your participants.
Yeah, I think so. And I think, I mean, it was a different aspect of the research that we're not focusing too much on today. But I think some social workers who are employed by trust working in a very good team. And it is like a snapshot. It's a moment in time. Teams change, don't they? And organizations change how they deliver services. But when I met social workers who were employed by the trust, working in a positive team environment, they were very complimentary about that. Some other social workers who I met who were employed by local authority often had a really strong sense of still belonging to that authority, and that's where the anchor was for their professional identity.
Mm.
And I think they had a slightly different take on things.
Yeah. And one of the themes you do talk about, I suppose, in relation more to the difficulties and the positives, is that people maybe found it hard to kind of have a different perspective to that of their health colleagues. Can you say a bit more about that? Why did that difficulty occur, and how did people describe it?
For me, that does tie in the two ideas about your people's essential ideas about mental health, mental distress, what might cause it and what might help, as a kind of both a kind of philosophical position, and then kind of a thing about knowledge and training and what you've learned about that in your own
Mm.
professional training and working life. And then also this idea of kind of how many social workers are there in the team.
Yeah.
So I met quite a lot of social workers who were they were the only social worker or one or two social workers in quite a large team. So you have a social worker who broadly will be trained, would have learnt lots of stuff around social justice, about human rights, about a social model of disability, will be thinking about their profession being a values-based profession. And that's what they're bringing into the room, perhaps. That's what their perspective is informed by. Then often they'll be working with many colleagues who don't necessarily discount those ideas, but it's not the basis of their training. It's not the core of their professional identity. So that experience of being in a minority profession and always perhaps having to challenge within the team to say, aren't we just really focusing on things that are a little bit too medical here? Aren't we ignoring the kind of intersectional aspects of this person's situation? Aren't we ignoring, the family background or the isolation? Not that other professionals wouldn't think about that or acknowledge those factors as being important,
Mm.
but it's not their raison d'etre. It's not what they're coming into first of all necessarily. And so I think that's what social workers found challenging in terms of getting their view across and asserting their view.
And you mentioned, I suppose, that people had different kind of employment statuses. I mean, did that make a difference? Were you able to tell? So, did people feel more comfortable to maybe assert themselves if they came from a local authority background rather than being employed by the trust, or was there not maybe so much of a difference?
Yeah, no, that was what I found in the wider research that I did. That social workers who retain their employment with the local authority, who might still be co-located, but there were kind of those subtle things of working life that create distance and some separateness at times. They often seem to be able to be a little bit more independent, essentially.
Yeah,
They weren't separate from the kind of integration project necessarily. They weren't kind of dissing the idea of MDT working at all, but they just retained something that enabled them to say, well, that you might think that, but I don't.
yeah,
And I feel confident thinking something different because I have essentially behind me a different organization and a different management structure and colleagues where I think I'm going to be okay saying what I want to say. And that was also really evidence in social workers who were approved mental health professionals.
yeah.
So social workers who've done that additional training, have particular legal knowledge, and are occupying a particular role. They seem to have that kind of higher level of confidence too. So it was slightly contradictory picture because I met social workers working within a trust who valued that experience
Yeah.
and valued the multidisciplinary team working and thought it was good and that good work was done. But sometimes they struggled to articulate their social work perspective a little and have the confidence and influence.
And I guess I'm just maybe aware that I'm at risk of making it sound more negative than it is, because I think it seems like the social workers are highlighting the positives more than negatives. And I just wonder if you can give some examples about sort of collaboration or where people felt that the kind of model that stood was helpful in that regard.
Yeah, so some of the social workers I met, I think, really valued the idea that the burden or the responsibility was shared, and that because that was the case, more could be done and better work could be done. So when you work in mental health services, sometimes you're working with people who are in acute distress, and that presents its own challenges. You're also working with people whose difficulties may be quite prolonged and extend, over quite a time period, and services may have always struggled to really help and support that person and their family or the kind of network. And that's a lot to hold as an individual practitioner, and that's a lot to try and do.
Yeah.
Yeah. So if you're in a well-functioning team where perhaps there's a team approach to risk assessment, there's a team approach to case management, where that kind of burden is shared, that seems to be viewed as really positive. So there's something about good team working and sharing the load. There's something about the best form of MDT working, that yes, you have lots of different expertise, and as long as the team is working well, that's going to be really helpful. It's really good to have a psychiatrist who's highly skilled in understanding somebody's mental health issue from a medical perspective, and prescribing medication in a thoughtful and sensitive, effective way. It's really helpful to have someone from an occupational therapy perspective who might have an eye to the need to be looking to the future and meaningful activity. It's really good to have a social worker who's saying, hang on, this isn't right. This person's being treated quite poorly in this perspective. We should be challenging that. All these perspectives are really valuable. So when it works well, I think the outcome for service users can be really good.
So, if you're thinking about why it works well, I mean, there's a couple of things you mentioned. I mean, the first is kind of sharing the burden of risk. So, is it the case that people are just less likely to be defensive about risk decision making if you're with other professionals, I guess?
Yeah. So as we're talking now, my sense is that risk decision making is likely to be more positive when it's supported by other colleagues. So
Yeah.
I think that's quite hard for an individual practitioner of any background, not just social work, to make positive risk decisions in a mental health context if they don't feel supported by their team. So I think, positive risk taking is much more likely to happen when there's a good team functioning.
Yeah. And it also sounds like it's about, I suppose, how quickly you can access other professionals. So, if you were based in different teams, then you kind of have to put a referral in, and that hangs about for several weeks or months or whatever. But it sounds as if the better practice was also promoted by the fact that you can maybe talk to your colleagues and
Yeah,
they'll go
definitely.
out.
Yeah, some of the kind of the data that's presented in the article, there's a note about pulling together. People seem to talk about a tightness and a pulling together, quite kind of visual in the words they use to describe good team practice as being the benefit, all working towards one aim. So that's the sort of contradiction of Bourdieu's ideas as well. Really, is that MDT working should be a positive endeavour to support people better. Yeah, Bourdieu is talking about how we all try to accumulate capital and influence. So there is, from this perspective, there is competition within the team between individual team members as they try to assert their position, to jockeying to be the most influential and that sort of thing. So that process is going on at one level,
Yeah.
but at another level, hopefully, so is good, productive team working that's helping service users.
Yeah. And I guess one point you bring up is that you talk about Bourdieu's theories and say he kind of likens Habitus as a kind of game.
Mm.
I mean, how useful is it to kind of use that analogy, I suppose? I mean, do people see it in those terms, do you think? Practitioners, I'm thinking here.
Yeah, he talks about having a feel for the game. And I think, perhaps drawing on my experience of working in those kind of teams, is obviously as a member of staff in a team, you have a view about what's going on around you. You have a view about which colleagues seem to be doing well, or perhaps are favoured, or seem to have more influence, or you might reflect on your own experience, how you do or don't seem to be able to get your view across or work in the way that you'd like to, for kind of interpersonal aspects of team working or organizational aspects. So in that sense, we all have a feel for the game, and it's not to trivialize it. The word game is quite a kind of light word. It's not to trivialize the activity, but it's just for me, is an acknowledgement that wherever you sit in a particular organization, you have a particular perspective, and you have a view about what might be occurring on different levels you don't know. And he also talks about how you don't necessarily know all the rules.
Yeah.
And there are things going on that perhaps you're not privy to in other people's working lives, in other professions, experiences, and so on. So you have a feel for the game as you're trying to kind of accumulate your own, professional capital, symbolic capital. And we haven't talked about it so far, but Liz Beddoe, the academic from New Zealand, talks about the idea of professional capital, which is really interesting too. So she took Bourdieu's ideas and developed, I think, the idea of professional capital, where professionals are trying to have a distinctive space to create some separateness, to say we're different, which is interesting to think about. But also talks about the idea of mature capital, which I really like, which is the idea that all these processes might be going on consciously or subconsciously within professional working as people are vying for position. But if mature capital is present, that doesn't necessarily mean that people can't work together effectively. So there will always be team debates. There will always be different professions and different members of teams thinking something should be done slightly differently, or this professional seems to have much more influence than me, and so on and so forth. But if it's a team that's working well, that doesn't preclude it producing good work and having good outcomes for service users. So I sort of like that idea, because the idea of field and Habitus and capital does, it's drawn from the idea of economic capital, which is drawn from capitalism, which is essentially competitive, and everyone's competitive to a degree. But I just like the idea that good work can also happen.
Yeah, that's a really interesting thought, Rob. And yeah, it's good to see it in those terms. I guess one last question is that, could you tell us what you think the relevance of your research is for social workers or social workers working in mental health teams? Why might this type of research be useful to them, do you think?
I think the research has essentially extended our kind of knowledge about how social workers experience multidisciplinary team working, which is interesting from an academic point of view. I think what we've learned, which would be interesting for practitioners, is that there are many positive aspects to this way of working, and hopefully that benefits people who use mental health services. I'm really drawn to the idea of shared knowledge and shared expertise. I think that's, it would be kind of perverse to deny that in a way. But also there needs to be room for different professions to have that identity and sort of claim different areas of the work. So I'd hope a practitioner reading the article would, by the end of it, have that sense of positive social work practice that I got during the research, and also think that it might be a struggle sometime to get my voice heard. I might be a little bit tentative, and that was one of the findings, that practitioners are a bit tentative in expressing their kind of areas of expertise, but that it is possible, and individually and collectively, social work should persevere with that. And the two areas of kind of particular expertise that came out from my research, and there are others, was around bringing a sociological perspective, and no other profession will be doing that as a starting point. And that's really important. Just as social work won't bring a medical perspective as a starting point, but they appreciate it. It's social workers who've been trained and have thought about and written about looking at the holistic aspects of someone's situation, seeing them in their social context, appreciating the importance of connections, family, networks, and so on. That's the starting point.
Yeah. Okay.
Yeah.
So thanks ever so much for your time, Rob, and for coming into the studio and talking us through that. If you're interested in reading more about Rob's research, the article is called Capital, Collaboration and Identity, a Bourdieusian Analysis of Social Work in Multidisciplinary Team Practice. It can be found at the British Journal of Social Work. It's free to read, so please have a look. Rob is based at the University of the West of England, so if you want to follow up with him in any way, you can find his details online as well. So thanks very much, and see you next time.
Thank you for tuning in to this episode of the Exchange Wales podcast. At Exchange Wales, we connect researchers, practitioners, and people with lived experience to share evidence, practice, and insights that shape social care. Our work spans children's and adult social care, and we're also exploring the growing role of artificial intelligence in the sector. If you'd like to learn more or get involved, please visit exchangewales.org.